Well, good morning, everybody. I want to thank you for joining us this morning for this. It's an all new style West Midlands Combined Authority Thrive at Work networking webinar. There won't really be too much networking today because we've revamped the style. We haven't held one of these since our offices in Birmingham were open. We would normally have around 30 attendees. They would just be limited to organisations that were participating in the Thrive at Work program, but I can see we've got 361 people online as it stands. We're hoping, we do believe we will get to the maximum 500 today because there's been such interest in this. We've opened this up because it's such an important topic. We have opened this up to anyone and everyone who may have an interest in this this subject of suicide, and as I say, we will be talking about prevention today. We have had some technical issues, or some of our panelists have had technical issues, so do bear with us because I've got 4 great people. I know you can only see 3, but I have 4 great people who will really make a valuable contribution to the conversation this morning. So I just want to cover a little bit of housekeeping. So this is a Q&A style event. We do welcome your questions. And if I can ask that any questions that you have throughout the morning, if you can pop them into the tab on the right hand side, which is literally called questions, I can see those. I can see that some are coming in. I can see that some people are having issues with audio. I know that somebody said that you can see all 4. Well, I wasn't putting me in that lineup of the greats. Sean Russell is yet to join us. He's just logging back in. So just bear with us. We might have to rejig the order because, like I say, every panelist has something really valuable to contribute this morning. Now, because we are touching on such a subject such as suicide, during the course of the morning, you may feel that you find yourself upset, distressed, by the topics and the information that's being covered. That's not our intention. We actually want to empower you to go away and begin having well-being conversations, or just have a better understanding of how the mechanisms around suicide and the mechanisms around prevention. If at any point you do feel like this is a little bit too much, I would encourage you maybe to turn off your audio. Because we're expecting 500 people online. If you log out, you might not be able to get back in because somebody might have taken your seat. But in the right hand side, you can see there is a tab called handouts, and in that tab there are 2 sets of information. One is for Mind, and then the other one is also contact details for a number of organisations such as Samaritans, the Cameron Grant Trust, and Papyrus as well. If you need to speak to somebody, please do use those details, make a call. We don't want anybody leaving here upset, disempowered. Like I said, we want to empower you and encourage you that there are steps that you can take to help others. But if you find that you're in that situation, then please do reach out and speak to somebody. So without further ado, Sean has joined us now. Great to see him online. Is your audio working, Sean? Yes, wonderful.
Thank you. Sorry about that.
No, that's okay. That's great. So I'm just going to ask our panelists to introduce themselves so that you know who we're speaking with this morning. So, and I'll just go from left to right. If I can start with you, Elaine, and ask you to introduce yourself.
Morning, everyone. I'm Elaine Woodward. I work part-time for the Local Government Association and Association of Directors of Public Health, the Suicide Prevention Programme Manager, which means that I support the local authorities' public health leads in suicide prevention. I've worked in the area of suicide prevention about 3 or 4 years, but before that worked in mental health for most of my adult career. Yeah, nice to meet you. Excellent to see such a fantastic turnout.
Thank you, Elaine. And I just want to touch on that because you are a suicide prevention lead. So kind of like for someone like me who kind of wouldn't know, and there's a number of organisations that you're involved with, and I do want to touch on the Zero Suicide Alliance that you're an advocate for. So on a practical level, on a day-to-day basis, what is your who do you interact with? You know, we've got lots of businesses online. Would they be interacting with you? Would you be making contact with them?
Probably not, because I cover 14 local authorities. I tend to support the suicide prevention leads in every local authority, and luckily all our local authorities through the NHS have received additional funding, so we've got some fantastic projects starting across the West Midlands. So I tend to support them and share good practice from my experience of working in different parts of the country, keep up to date with all the research and share that, and just be someone who can support other people. And what's different about suicide, say I've worked in mental health a long time, suicide is quite different because it sounds trite, but it's everyone's business, and I'm going to hopefully go into more details, but we can all prevent suicide. You don't have to be a mental health expert. There's lots of experience about that. So although I don't work actually with businesses, although I do with my other hat on as a mental health first aid trainer, but we can touch about what people can do, and hopefully that will come across, because I'm doing a bit of a very short presentation. Hopefully people will be inspired that they can really help to make a difference and prevent suicide.
Okay, thank you, Elaine. If I can come to Doreen next.
Okay, hi, good morning everyone. Again, great to see a good turnout. My name's Doreen Till. I'm Employment Retention Team Manager with the Black Country Healthcare NHS Foundation Trust. Basically what that entails is I help people return back to work who've been off sick with mental health problems. In terms of my mental health experience, I've worked in mental health for over 20 years now. You know, obviously done a lot of work with employees and employers, trying to help maintain the employment for our patients when they return back to work. Oh, I've lost the sound, Andrew. I can't hear you.
That's because I'd muted myself and forgot to. We are live, folks. I do apologise for that. So, so Doreen, I know that your organisation interacts with our Thrive Into Work programme as well, doesn't
Absolutely,
it? So there is
yeah.
a resource there that's available to businesses, and I think from July that will be across the whole of the West Midlands region. Sean, can I come to you next?
Yeah, good morning, Andrew, and really appreciate the time that people have put into bring this together, but also for the businesses who are online, which is really important. We've got over 400 businesses, I think, currently online, which is amazing. So I'm Sean Russell. Up until recently, I've been the head of Thrive. So I've been the founder of the Thrive programme for the West Midlands Combined Authority for the last 4 years. I've currently got a senior lead in the COVID response for the West Midlands arena, which is really exciting, but also we'll be picking up some of the challenges that we're talking about today and what that looks like for us as we proceed further forward with recovery. My background is I've actually got 27 years as an operational police officer, finished as a senior police officer very recently. But most of my time in the police service was looking after vulnerability, whether that was vulnerable adults, vulnerable children, but then specialised in mental health and had the force lead for about 10 years. Which has enabled us to do lots of work around how we improve people's well-being, but also to try and stop people who are unwell getting into the justice system, and then supporting those people who are really, really vulnerable at that time of crisis. So I'm really pleased to be here today as part of the panel, and then hopefully we can share some of the best practice that we've developed over the last few years and actually take some of the myths away from the suicide issue and some of the challenges that is, because as Elaine's already said, it is everybody's business and we've all got a role to play and a part to play, but it's about understanding how we can make that happen appropriately.
Thank you, Sean. And just to say, yes, in footballing terms, the transfer window opened in January. We took our eyes off Sean. And when we looked again, the Mayor had taken him on loan until the end of the season. And I don't know whether the Mayor's online. I'm not expecting him to be, but I do want to say we do want him back at the end of the season because we've got lots of work to do. But I think that was testimony to the work that Thrive at Work has done across the region. You know, all of the businesses that have participated in Thrive at Work said that when lockdown came last March, it had prepared them to respond flexibly and empathetically to all of their employees, and they've said that it's been one of the things that's made a big difference. So if you're online, you don't know anything about Thrive at Work, this isn't a promotion for Thrive at Work. We want to add some value to the region today through this conversation. But I would just ask one of my colleagues who's online from the Thrive at Work team if you could just put the web link to the Thrive at Work page into the chat, and then anybody that wants to find out more about workplace wellbeing and how to go about it, where to start, then that would be a great starting point for you. Thanks, Sean. Evan, if I can hand over to you.
Andy, thank you very much. Thanks for the chance to be on this panel, and as everyone else has said, thank you. It's great to see so many people have joined us in this conversation. So my name is Evan Grant, and I'm the chair of the Cameron Grant Memorial Trust. I work in suicide prevention and mental health awareness because 6 years ago, in late 2014, my 21-year-old son Cameron took his own life. And when he died, nobody knew that he was ill. But in fact, to the contrary, he seemed to be thriving, enjoying his life at university, enjoying playing ultimate frisbee. He was active physically, socially, and things seemed to be going really well. But he left us a letter, and in his letter, he described suffering from symptoms of depression for more than 7 years. It dated back to when he was still 13. We so wish that Cameron had asked for help, because it's pretty easy for us to believe. We'll never know, of course, but it's easy to believe if he had asked for help, he would have been helped and he'd still be with us. So the message that we communicate as a charity is that there is always someone you can talk to, and we work with communities around the country to highlight where you can go to talk to somebody. And these are schools and universities and workplaces, police federations, and anything that's a community. And we specialize in actually putting the help information out that's relevant to that community. So that's our message, because Cameron chose to suffer in silence. Our message is there's always someone you can talk to.
Thank you, Evan. And there is something just before we let Elaine share her slides. There is just something I wanted to touch on, which I'll bring you back in, Evan, and probably possibly you, Sean, as well. So we in our communications and putting information out about this event, we sent an email out to the Mayor's Faith Network, and I was very grateful to Reverend J. Nicholas Latham, who responded with a very useful comment. What he wanted us to say was this: while not part of today's agenda, we do recognise that when someone takes her or his own life, those who are left behind may have feelings of failure and guilt. Our efforts to prevent suicide have not succeeded. However, usually there is no reason to blame or reproach ourselves. I know that bereavement and certainly surviving suicide is for another day and another topic. So I don't really want to labour the point, but I do want to acknowledge that. And I just wondered if you had anything that you would want to add to that, Evan.
Yes, well, indeed, as you say, that would be worthy of another call, but it bridges directly, because being bereaved by suicide is a risk factor for suicide. So quite apart from my demographics and my age, the fact that I've lost a son to suicide, it's a population risk, but it makes people that have been bereaved by suicide are more likely to die by suicide. So there's a very strong direct link, and offering appropriate bereavement support to people who've lost someone to suicide is a means of reducing suicide. Okay.
Sean, is there anything that you want to add?
I just think Evan's just covered it really, but I think the bit for me is that guilty feeling is always there. We always try to be effectively superheroes in all of our worlds, and actually sometimes it's not possible to do that. And actually all we can do is do what we've done, and making sure that things like today, where you learn the appropriate opportunities to engage, and actually we give people the best practice, actually that you can do as much as you can do. And actually the fact is that you're doing something is better than doing nothing. And that's so important.
Okay, thank you, Sean. Just before I hand over to you, Elaine, I can see there are some questions that are coming into the questions box, but it's just about today, and will slides be made available? And I just want to say, because this is the first time we've done this event, we will be sending out an evaluation survey. I think it's 15 questions, most of which are yes or no, or mark us out of 5. Please we'll send that out first, respond to that. This event is being recorded. We will make it available to you. If you respond to the evaluation survey, you will get it a lot quicker than those who don't. We just want to know that, you know, what we're doing is effective and is making a difference and is adding value to you. You guys have all taken, you know, we're taking 90 minutes out of our day today just to learn about suicide. Every 90 minutes, somebody across the UK ends their own life. So, you know, before we started at 10, that may have happened. By the time we finish at 11:30, that may have happened a second time. So we really want what we're doing to add value. On that note, please do keep the questions coming in the question box. But I'm just going to hand over to Elaine now for you to run through your slides and just bust some of the myths around suicide.
Just need Kirsty to give me permission to do it, please.
Hi Elaine, you should have that.
Oh, should I?
There you go.
Right, thanks. Good. Can everybody see that?
Oh, yes.
No.
Can you? Oh, share my screen. Oh, did anybody see my slides?
Yeah, perfect.
Oh,
Yeah.
well, sorry, I can't see them now. Sorry. Right. Yeah, so people can see my slides. Yeah. So you need. So sorry to yeah, this is a Q&A session, but I thought it would be useful just to have a few slides so that we can really focus on what are the key issues. And I'd just like to start with this slide. And I don't want to sound too politically correct, but one thing I'd really like you to take away today, if we can avoid saying commit suicide, it's really hard not to. And I'm forever challenging the BBC for them because they still use it. The reason we don't like people to say commit suicide, because for families it's got an association with crime, or sorry, that should say sin, and suicide has not been a crime since 1961. So if you could say things like died by suicide or took their own life, though I do accept that people will still lapse back into commit suicide because it's so ingrained in our language. Next slide I'd like to show is a quote, because anybody who's worked with anyone who has attempted to take their own life, and including those people who really thought they would die but were saved, they all feedback that they didn't want to die, they just didn't want to cope with this pain anymore. So suicide is not a method to die, it's a method to end pain. So that's what I'd really like you to hold on to, another key message I'd really like you to take away today. This is quite a busy slide, but it's really to show the prevalence data. Only a coroner can reach a conclusion of suicide, and the latest data we've had came out in September 2020, and at that time there were 5,691 suicides in England and Wales. And of those, 3/4 of registered deaths are amongst men. And wherever I've travelled in the country and spoke to people, everywhere you go, it's always 3/4 are men. But we can see some trend of a rise. So there is a bit of a caveat in that the coroner were instructed to change how they reached their conclusion of suicide from beyond reasonable doubt to the balance of probability. So we do think that may have had some impact, though we did still think that suicides were on the increase. Males aged 45 to 90 are the highest risk age group, which surprises most people that I come across. They tend to think it's young people. And for women, the highest age rate was 50 to 54. And despite having lower numbers of death rates, overall the death rates for young people have been seen as being increasing. And I've got another slide on that a bit later on. Another really key message: only 1/3 of those who died by suicide were known to mental health trusts. So, so 1/3 were known to mental health trusts. 1/3 had contacted their primary care, their GP, but didn't necessarily talk about suicide or risk of suicide. And 1/3, usually young males, weren't in contact with any services. That's why we say it's everybody's business. We can't rely on it being a mental health trust employer that will work with people who are at risk of suicide. Not having a go at mental health trusts, but interestingly, even they in research have been found to find it really difficult to assess who is at risk of suicide. But yeah, so this is quite a busy slide. I'm just trying to show the age range, and it shows again the peaks for males as being in the middle-aged men. This was an article that was in The Guardian a couple of weeks ago talking about children and young people, and it's, you know, some quite worrying statistics there. It's quite a busy slide, but you can see that although they aren't the highest risk group, there is concern just how frequently young people are thinking about suicide. And there's a reference there to self-harm, and we know that that's a really key risk factor. People who self-harm don't tend to want to die by suicide, but sometimes some of their methods of self-harm can lead to death or serious injury, and it is a risk factor for people completing suicide. Lots of you can see I'm a bit stat mad. I just threw this one in because Birmingham and the West Midlands, lots of construction going on because of the Midland Metro, HS2, Commonwealth Games. This is quite a worrying statistic that you're more likely to die in construction from suicide and self-harm than from physical trips and falls. And I think that's quite an amazingly worrying stat. And luckily the HSE has really taken this on board, and they really try and promote that. But that's another key message that we really would like you to focus when you're doing your health risk assessment at work. Don't just think about tins of paint and scaffolding and things like that. Think about mental health, and there's some fantastic resources on the HSE website about stress and other mental health issues at work. This is, we can come back to this a bit later, but this is really just to show the age range, sorry, the prevalence range, and we'll pick this up a bit later, but there do tend to be higher rates of suicide further north and in rural and coastal locations. So key risk factors, you can read these for yourself, but we've touched on them briefly. So people who've made previous attempts, have a family history of suicide, as Evan commented on, access to lethal means, that could be medication, it could be shotguns, so people who work in the agricultural industry, for example, could be access to railway lines. So we do a lot of work in suicide prevention, could be looking at that. People who've been diagnosed with a mental health issue are socially isolated, so you can see the links with COVID, have been unemployed. And this is a quite, sorry, I know I sound statistic mad, but this one here about in the last recession, for every 1% increase in unemployment, there's a 0.79% increase in suicide. And that's, I think, quite shocking, really. Those who are homeless and those who have a serious illness. So I won't really go, but Rory O'Connor, who I really admire as a professor, talks about those people who feel that they're a burden, because people have said in the past, people who take their own life, how selfish they are, but actually it's a complete opposite. They feel they're a burden and want to take that burden away from their family. I'll skip these because I'm conscious of the time. So, but concentrate on the myth. There is a myth that those who talk about suicide don't go through with it. That is a myth. If a person is serious about killing themselves, there's nothing you can do. That is a myth as well. You have to be mentally ill to think about suicide. They're all myths. Sorry, it's a fact that 1 in 5 people who have thought about suicide, but do not go on to complete suicide. As I've mentioned before, those who are suicidal don't want to die. And a myth that I really want to challenge today, talking about suicide is a bad idea. It isn't a bad idea. I always say the worst you can do is upset someone, but you may help save their life. These slides will be available. That's why I'm not reading everything out in them, because I really want to get back to the Q&A. So in terms of the impact on COVID, we can only really look to 2003. I wasn't aware there was a respiratory epidemic then, but somebody's pointed it out to me. And we found there was a 30% increase in suicide, and 50% of people remained anxious post the epidemic, and 29% of healthcare workers experienced distress. And as I mentioned, that really worrying statistic earlier, that for every 1% increase in unemployment, a 0.79% increase in suicide. So we do know that the risk factors are things like economics. We know where domestic violence is on the increase. There's varying research about alcohol use at the moment. Obviously, we can all relate to social isolation and the lack of bereavement, and the people able to go through the grieving process because of COVID. These are all risk factors, but that's not to say that we can't do anything about it. We need to be aware that unless we do something about it in suicide prevention, we could be seeing further increases to suicide. So I can share these, but there's some really great free resources available, and hopefully I can talk about them a bit later on. Zero Suicide Alliance, that was set up by a father very much like Evan, whose young son died, who said we should all aim that there's no suicides in this country, and developed can you believe it, a 20-minute training that can teach you how to talk someone out of suicide. There's a more in-depth training which is 60 minutes, and then stayingsafe.net. Alice Cole-King, who's another fantastic person working in suicide prevention, said we should all have a safety plan to keep ourselves safe, and that website will sort of teach you how to, or show you how to fill in a safety plan for yourself and loved one. I told you I could talk fast. I've now finished, so yeah, I'm not quite sure how I get out of this, but I have now. Yeah. Kirsty, do I just whoops. Have I closed the slideshow?
There you go.
Yeah.
And we're all still online as well. So, okay, we've had some. We're going to go to a Slido in a moment because we wanted to make it as interactive as we could. But there have been quite a few comments and questions that have come in on the chat box on this. I want to rush through. Not that I want to rush through. I want to get through them quite quickly because I want to get on to the subject of safeguarding so that Sean and Doreen get to speak before they have to leave us before the end of the session. So first comment is just to make people aware, today is Uni Mental Health Day. I wasn't aware of that. I think we're quite fortunate that this has landed on Uni Mental Health Day. And again, I would just say to my colleagues from Thrive who are online, if you can make a note of that and let's get it in our diary for next year so that we don't miss out on that. Here's a question. Do you ever find individuals are focused on worth, the feeling that they are not worth the help and support being offered? Great question. And I'll open that up to the panel, to whoever wants to.
Yeah, I think in terms of that, I think you know, sometimes the emotional state of people will cause them to think they're not worthy of support or help, and this is a key issue really, where people need to. Sometimes we can be so engrossed and so stressed that we don't actually notice ourselves, and sometimes it's the people around us that can pick up on some signs, and it's that kind of fear of intervening, I think, in terms of the general public. So it's really important that people can feel that they can just ask someone, you know, how are you, how are you feeling, if things felt so bad that you felt like ending it all, and it just opens up that conversation with that person. But again, you know, people feeling that they're not worthy of help, again, is part of a kind of depressive state of mind, really, in terms of feeling that that people, you know, just aren't interested or wouldn't be interested in their concerns. And that's why it's really important to that kind of reaching out, really, because when someone's really that low, it's very, very hard for them to see that they need some help themselves. I don't know whether anybody else wants to comment on. on that.
Only to say that's why I love the work of Rory O'Connor that said one of the biggest risk factors if you feel that you're a burden to other people. Yeah.
Absolutely, yeah.
That's great. Thanks all. Lots of questions and comments coming. Some really good stuff as well. I'm gonna park them for now because I want to do the Slido and then I want to talk about safeguarding. We will come back. If we don't get to answer all of your questions during this session, we are going to do a follow-up information pack that's going to have a lot of signposting resources in there, and hopefully amongst the panel we will get answers to all of the questions, even if we have to kind of group them together and put an answer out to you, as you know, answering 2 or 3 questions in one statement. So here's your Slido. So hopefully you've all got access to your Slido. Here's your question. Oh, so people have been at this already, have they? Do Cornwall and Norfolk have higher rates of suicide than London and Birmingham? So Kirsty, is that okay? The responses are coming in. I can see them counting up. So we'll just give that. We'll just give people a minute to answer that and see how that comes out. So whilst people are responding to that, let me just say, so help is at hand. Supporting those bereaved by suicide is a resource from forwardforlife.org. We will include that in our resources that we send out afterwards. So thank you for sharing that one, Terry. There are some questions here. Is it higher for men because they use more lethal methods? I don't know if one of the panelists want to just briefly comment on that.
So I'll bring in if that's okay. So really importantly, it's not necessarily because they use more lethal methods. Actually, it's because men don't generally talk and their social networks are slightly different. So forgive me, and I don't want to stereotype, but females have historically been able to have chats with their girlfriends, have a conversation. They might nip out for a glass of wine or a meal and have a conversation and really put the world to rights. Men really struggle with that, and there's been some really good initiatives such as Men in Sheds and It Takes Balls to Talk, which really focus on men opening up. The other side of that is that men have historically always been the breadwinner. So actually where there's a financial drain on a family, it feels that it's absolutely important that we get this right, and men feel the real burden therefore of providing for their family. And as one of my very early days in the police service, I went to a really awful event in Birmingham where unfortunately father had lost his job and decided to take his own life, but also took the life of the family around him too, because it couldn't quite believe that the family would be able to cope without him. And that for me was really a seminal moment in all of this work, and that was 3 young children and a wife and him, and it's really, really important that we get that message out there.
Okay, thank you. Just to say, so yeah, go on, Evan.
If I just add add to what Sean said and build on what Elaine said, that the clear trend that suicide deaths are about 3/4 men, but actually attempts of suicide are higher amongst women. So it's easy. It's also a problem for everyone basically. So the deaths clearly are worse for men, but I don't want us to avoid the fact that suicide is also for females.
Yeah. Okay. And of course, if you self-harm, I think it's about 100 times more likely to take your own life. So it's quite high risk if someone has a history of self-harm.
Okay, thank you, Doreen. Just want to say to Kirsty that we can see the Action for Happiness website, and I've lost the Slido slide. So if we could have that back on screen, that would be helpful. And then we will move into the safeguarding. Can we get an answer to the Slido? I think Norfolk and Cornwall were ahead of.
Yeah, so that was my question. So yes, they do have higher rates, and one of the reasons it's complicated, but one of the reasons is that Birmingham, like London, is a young city, so there are fewer middle-aged men, for example. That's very simplistic, but there are other issues in Cornwall and Norfolk to do with access to means, including firearms. I know there's been some work going on there, but so yeah, most people would think that living in the city would put you at high risk, because it does for some mental health issues, but actually Cornwall and Norfolk have got higher rates than we have. London has got probably the lowest rates in the whole country.
Okay, that's great. We'll come back to another Slido question in a little while, like I say, just to keep it interactive. I want to talk about safeguarding now, and we will come to the questions in the chat box, but I just want to get this. I think there's some really useful information here that businesses may not, and organisations may not be aware of. So the reason why we set up this webinar didn't exist, wasn't in our thinking just over 3 weeks ago. But we learned of one of the businesses that we work with, which is a micro business, employs 10 people. They had experienced somebody, but one of their employees commit suicide. They then had a second employee who was very poorly and was having some extreme mental health issues. So they were able to talk to him in a meeting like this online, but he wouldn't put the camera on. They were aware that there was possibly a wife and a child in the background, both crying. And obviously, your HR policies aren't really designed for this kind of extreme situation that some people are facing, but there is help out there. GDPR, who can I contact? What can I do in a situation like this without breaching confidence? So in a conversation with Sean, this webinar was really born out of a conversation with Sean when he started to speak about information that he was aware of that would be useful for businesses. And I know that, Doreen, this is an area that you work in as well. So I'm going to open it up to both of you. Safeguarding is the issue. If you have got somebody that is poorly and you're not sure how to support, perhaps not a 999 call, but you do want to help rather than just implementing HR policies that might mean, well, we start to discipline this person. That's the last thing that you want to do. How would you approach that situation, and what is available out there?
Okay, so we take it in two parts, if it's okay. First of all, so you're in the office or work environment where they're in front of you there and then, and that's the first bit. That's probably slightly easier. So your ability then to have the conversation with that individual, you would basically assess them to say, are they in imminent danger? And if they are, absolutely the right thing to do is to call 999, the same as if someone was having a heart attack. You do exactly the same. And really important, you get that help immediately, making sure that person isn't left alone. So stay with that person and use a listening ear. Start to be a person who starts to listen to what they're saying and start to make sure that you're not judgmental in your approach, because we all might have our stereotypical views of what people in this position might be like. But actually, for the moment in time, that individual is going through an absolute crisis and they don't want to be judged. They just want to be heard. And for you, it's about being empathetic and supportive in that space. So we want them to encourage them to be talking as much as we can. We've got to make sure, though, whatever they say to us is not held confidentiality. There's no confidentiality here. If you're in someone in crisis, we've got to be clear with them that actually that we can't have that conversation in a confidential way, because it needs to be shared to make sure that we get the best help for that individual, and we will share that with broader partners for the purpose of helping them. What we then need to do is make sure that we get an approach to the GP or similar. So some of you might have employee assistance programs, but actually what we would encourage that individual to speak to the GP. And I've been in rooms with people in work and we've actually rang the GP surgery there and then, and we've supported that conversation in that space and enabled that to take place. The first bit is also trying to get through the receptionist, because that's always really, really difficult. But actually when you get through that first bit, actually you can sit with them and then work that through, and that's really, really important. And then actually ask them what they need, because actually this is what's important to them. They've got to a pit of despair that we really need to think about, and that for me is so important that we can do. We might be able to do something there and then within our own gifts to be able to support that. So that's really, really helpful. And then effectively just stay with them. So that's the first bit around the workplace scenario when you've got someone. Now actually most of our organisations now might have mental health first aiders, and we've got lots of those people within our organisations, or we have various other connections to other people, such as the Samaritans and various other charities, which I know will be signposted today. So I think it's all about making sure that all of those are up to date in your organisation and people know how to do that. And the basic awareness for line managers is so important, because you're probably going to be the person who's presented with this. The second bit, though, is actually those individuals who are currently working from home or may not be in the home, who might be at the home space and not in the work environment. That's really hard, because actually what you might do is you might be doing Zoom calls or Teams calls, and you might not be seeing them physically, and you will know that they're starting to deteriorate over a period of time. And actually you can sense from the things that Elaine has said today, their mood has dropped, they're turning the camera off, or they're keeping the camera on and they're not looking after themselves the way they used to when they were in the office, and starting to see the signs and symptoms. And you can really start to think about, that's when the conversation with you as a line manager is so important. The early action for me is so important here. The next bit, though, is if you get to a stage where you've got to the point that you've described in your experience, Andy, around the organisation that came forward, actually there's lots of things we can think about. It's not just about you taking action. If you have a view that an individual is in immediate harm, actually you are absolutely within your rights to have a conversation with the emergency services, and the police are very well versed in that. And when I was in the service, I set up the street triage team, which was a police officer, a mental health nurse and a paramedic in an ambulance car, and we would go out to incidents like this all the time, because actually it's so important that we safeguard that individual so they don't take those next steps. The other bit you described is a lady in the background crying and the daughter crying. Actually, you know, that is potentially a safeguarding risk for children's services. You may not think that's the case, but actually putting a child through the trauma of experiencing, you know, dad who's not very well in that space and mum who's probably not able to cope is also a risk. And actually it doesn't mean that actually when you inform social services that you've got a concern, they're going to run in and take the child off the family. Actually, they can work collectively as a group to put things in place. So that's really important. And then finally, coming back to workplace, actually most organisations should have a wellbeing agenda within their organisation. And part of this is about actually how you deal with some of these issues. The Thrive at Work Toolkit is really, really strong and supportive of this agenda. And I'd welcome, as Andy said earlier, to get people to join. But also you've got Business in the Community. You did a really, really good piece on this back in 2019 and have a really good free toolkit and supported by lots of organisations. And then I've also known that actually on the webinar today, you've got some amazing organisations like Forward for Life and a whole host of other organisations and Common Unity actually, who are brilliant in supporting those community sessions. So this is about actually reaching out, so making sure that you don't own it on your own, you have the knowledge, you share it out to other people, and you get safeguarding support from the people around you to do that. So you should never feel that you're in a space where you can't ask. And worst case scenario, if you don't know the answer and you're feeling a bit confused, ring the Samaritans or anyone else and they'll be giving you advice there and then, because they're amazing at this response.
Yeah, I mean, I totally agree with everything that Sean says there. Just to add a few extra parts to that, if someone's got existing mental health problems, they may actually have a crisis plan that's pre-prepared. So they may have some kind of plan that they've maybe discussed with their clinicians about what to do in a crisis situation, which they may have shared with you as an employer. But certainly as an employer, you'll probably have contact details of nearest relatives and you know, the kind of things that we do when we first start a job and they just want an emergency contact in case anything was to happen to you at work. So you may have some details like that already. Also as well, in terms of support around the person, what we know is that you know, if a person's got some access to support, whether it be family or friends, or if we can build a little support plan around that individual, then the likelihood of them taking their own lives is reduced considerably. And it's this safety plan that Elaine was talking about earlier. You know, again, really, it's good practice for us all to have one, really. And the kind of things that we can do when we're in difficult situations or at crisis points in our lives, it's quite useful to look at what support we can build around us to protect us.
That's great, Elaine. Well, one of the questions that's come in, so was there somebody, did one of the other panelists want to add anything? No, that's fine. So I thought I heard something. So one of the questions that's come in is, are there any suggestions for helping someone who is currently refusing help to be more willing to engage. I'm working with a young man, 16, who's refusing any support offered.
So I think there's a couple of things really. I think it's important that you try and navigate, understand why they're not engaging, and that's so important. And some of that is about self-worth, as Elaine has already described, and feeling that, like, they're a burden. But actually, you know, there's lots of people within Doreen's world. You have things called assertive outreach teams, and their specialty actually is working with younger people and adults actually, who really struggle to engage, because it's not the easiest thing to come forward and ask for help, and lots of people do struggle. So I think there's lots and lots of tools out there, but actually if you get to a stage where that's the case, then reach out to some of us or to partners, and we can try and see what we can do to help.
Okay, that's great. Yeah, Evan?
Yeah, just to add to that, I think one of the, of course, we can't speak to the specific situation because we don't know it. But I think one of the fundamentals where somebody doesn't want help at the time is to always leave it such that they can get help later today or tomorrow or next week. Everybody, the way people might eventually accept help varies by individual too. So some people might find they can open up on a text service like Shout 85258. Other people might reluctantly take a web link or a PDF printed out and find that they've read it overnight or something. So you stay calm, stay supportive, and make sure that whoever you're talking to knows that at any point they can come back to get help. But I think also remembering that each person might need help in a different way is important. Just be calm and always be ready to help, and make sure that the person in question knows that your door's open, so to speak.
But in the comment, it's quite sad. People often have to be in crisis before they will seek help. You just have to keep hanging in there, because they will reach out eventually. And it's sad to watch people, but they often have to reach rock bottom before they can actually reach out for help. Yeah.
So one of the questions that's come in, which kind of touches on this, it says, do you have chaplaincy support in any of your working environments? Now, I remember seeing a piece of research which the New York Times did last year when the US went into lockdown, and it was around resilience, and they came up with 7 characteristics of resilience, 3 or 4 of which were faith-based. So I know, Sean, I know you've done a little bit of kind of work speaking to people in this area, so I'll get you to comment on that. And where there isn't chaplaincy support, I'll come back to Doreen again, because obviously, you know, your role is, even in retention, there is other, if it's not chaplaincy, there is this support that's available, isn't there? Sean?
Yeah, so overarching for me, chaplaincy support is a really strong element of the workplace wellbeing agenda, and actually they are really supportive of engaging with organisations. So there's an example on the Colmore bid in Birmingham. Actually, you have the chaplaincy support network. The chaplains actually go in and provide a listening ear. They are not non-faith orientated in their view, so they don't push the faith agenda, but actually are there to support. And I think that's so important. And I remember in my very early days as a policeman that actually having a cuppa with a chaplain was a regular occurrence, where they would come in and shut the door and make sure that I was okay, because actually I made a big point of looking after my staff in the really difficult jobs that I had, but actually who else looked after me? And they would make a point of coming in and having a 15-minute conversation just to make sure I was okay. None of that was about spirituality or faith, and although I have a faith, it was really important that we had that time just to have that non-judgmental conversation. So I would absolutely recommend businesses to think about how that works and to encourage them to do that. And lots of our local faith networks are really engaged in that agenda. And I know the chaplaincy John Latham, actually, who spoke about it at the very beginning, and a number of others actually have got amazing networks through the churches within the region to support this agenda. So really happy to support going forward with that as well, if we can signpost people to that agenda.
Yes. I think the bus company has a chaplaincy, doesn't it? National Express. Yeah, I think, which works quite well. In terms of support generally, across the West Midlands, we do have 24/7 helplines now that were set up really as in response to the COVID response. So people aren't in touch with mental health services, they can just ring up and get some general information about how to get referred. A lot of our services now, you can actually refer yourself. Services called IAPT, which stands for Increasing Access to Psychological Therapies. You can actually, if you Google the area that you live in and put IAPT, it'll come up with a number, and you can actually refer yourself to those services, to talking therapies, and get some support. So we've tried to make referral pathways a lot easier for people to access now. Obviously, main port of call for a lot of people medically would be through the GP. And again, GP could refer on to organisations, but there's lots of voluntary organisations out there, you know, in terms of, we've already mentioned about Samaritans. Samaritans are very well trained, they're very good service, and there's lots of other different services out there that people can just tap into if they just feel that they need to talk to somebody and reach out to somebody, even if they don't feel they can do that with their own colleagues or their family members. And very often, you know, to have a conversation with somebody who isn't going to be judgmental, you know, is very much supportive thing for everyone, I think.
That's great. A couple of questions coming about asking about the safety plan. Is a safety plan the same as a wellbeing action plan? And is there a sample of a safety plan available?
If you go on the website, it's geared for the general public, and Dr. Alice Cole-King will sort of talk you through how to do it. And it's things like pieces of music or going for a walk. It's so, yeah, so I would go towards this stayingsafe.net, and they will talk you through it, and so it's aimed at the general public. So it's not full of jargon and everything. So
yeah,
it's a bit different, yeah.
In terms of, oh, sorry.
Sorry, I've just added a link to the sample safety plan, and it's available in the chat and Q&A function for everybody.
Okay. In terms of wellbeing action plans, Mind produce a really good guide to that. They do one for employers and for employees. If you're not familiar with wellness action plans, they're brilliant, really, because it can be when I was talking earlier about somebody who can have a crisis plan, it allows the person to have some choice and control about what happens to them, really, and to identify potential triggers to their mental health difficulties. They may choose to share that with their employer or not, but at least then people will have thought, okay, I've had this happen to me, well, how can I prevent it in the future? So it's a really good tool for businesses to use, really, to think about wellness support.
Go ahead, Evan.
Yeah, thank you. And I'll just add to what Doreen said. I really like the fact that a wellness action plan can be for everyone and not just for someone that's ill and getting back to work. So 100% of us could have wellness action plans about how to keep well. And it's great to make an action plan for keeping well when you are well, as opposed to when you're trying to. And I think that the question asked as well, what's the difference between a wellness action plan and the suicide safety plan? And I guess a wellness action plan could include the safety plan, but I'm not sure if Doreen or anyone else can add to what the distinction between a safety plan and an action plan, a wellness plan, might be.
Yeah, I mean, I suppose it depends how much information the individual would like to share, but you know, sometimes people combine it with a crisis plan, a potential, or do the same. It depends if someone's had experience of mental health problems before. Generally, with our clients, a lot. What we try and encourage them to do is to come up with a wellness plan, because it helps them to give them some control and choice about what occurs and what happens to them if they were to ever to end up in a crisis situation again, who they feel comfortable being contacted, and what support mechanisms they'd want put in place if they were to become unwell again.
And there's a really simple part of it. It can sound quite complicated certainly when I talk about action plans and so forth, but the elements can be pretty simple. And one I really love is just remembering every day to think about something that's made you happy, and perhaps at lunchtime to think what are you going to do later in the day to make you happy, and just some reflection today or once a week about what's happened that's made you happy is a great part of a wellness plan. And it's something about our current society. We're very quick to dwell on the negative, especially in these COVID times. but when you look back over the last day or the last week, there's always something, even just a smile from a passing stranger, that brought up lift you. So thinking about what has made us happy and planning what is going to make us happy, these are great little things we can do to keep for our own health.
Thank you, Evan. I'm just conscious of time. We could only afford Sean for 1 hour. His rates have gone through the roof since he transferred to the Mayor United. So there is a question I want to ask of Sean, and it relates to one that's come into the chat. It says, have suicide rates or attempts generally increased due to COVID restrictions and working from home, or young students are studying from home? And I know that there was a piece, I think it was in The Guardian, I mentioned this before we went live, where The Guardian were questioning whether there was any mental health kind of epidemic off the back of the pandemic, and that the statistics weren't saying so. So we'll look at that, and I know Elaine's not in there. I know you've got information on that. But Sean, your position in COVID response. Obviously, we've got this roadmap out of lockdown now. From a health and well-being, from a mental health perspective, what is the expectation, and what should businesses be looking out for as people en masse begin to return to the workplace? Is this going to be back to normal, or should we be putting plans in place now to deal with mental health issues that people have been hiding during the pandemic?
That's a really, really good point, and I think there's again a couple of elements to this. First of all, that actually COVID has been the biggest cultural shift in the way that we operate in the UK, probably since the Second World War. And actually, it's seen lots of people now working from home. We've put lots of people on furlough. We've had significant numbers of people being made unemployed. So there's a real challenge for us in our region. And although the numbers don't seem at the moment to have gone up, actually we're still very early days. We're only 9 months into the pandemic. We're coming up towards 12 months now. But it's it's really, really difficult for us to understand what that looks like from that statistical position at the moment. The other bit for me is actually we are now living in a world where COVID is part of normal business, and it's going to be normal business probably for at least the next 2, 5 or 10 years, I think. And in my world, I'm trying to work on how do we encourage businesses to keep COVID safe going forward, so what we don't get is the re-emergence of the COVID transmission going forward. And you can see from the worrying sides of the P1 variant, the Brazilian variant, and actually the fact that only 6 people had got it, but they were pulling out all the stops to find that individual that wasn't they couldn't identify, just to make sure we didn't pass on that new variant. So this is how it's going to be for a while. Workplaces are going to be different to how they are now and how they have been previously. So the chances of people going back to full open plan offices in the short term is probably very, very minimal. We will be socially distancing, we'll be maintaining hygiene and keeping space, we'll be wearing masks for some considerable time, I would imagine. The fact that we've got a vaccine rollout is absolutely fantastic, but actually it doesn't stop you catching the virus, and it doesn't stop you passing it on. What it does, it stops you being very, very unwell, which is likely to end up in hospitalisation. And I think this is what we've really got to think about. So I don't want to see street parties on the 21st of June when it all finishes, if I'm honest, because I think what will happen is actually we'll end up back in another lockdown. So I think we've got to be really careful. The mental health, though, for me has been important, because actually working in the home environment now is very isolating. And lots of us who followed the rules all the way through have been really clear that we've had very little social interaction. All of a sudden, when that social interaction starts again, people start to get nervous, and actually there'll be accepted norms of people who want to go out and socialise and people who can't wait, but there'll be lots of people who'll be really nervous. And if you think about the number of people who have been asked to shield, we had a very large number in the first lockdown. That has been increased, I think, in the West Midlands by another 80,000 since the beginning of February, because we recognise the impact this is having on our population. So I don't want to go on too much longer, but actually for me, it is a ticking time bomb, if I'm honest. The mental health of our population has got to be something that we look after. We have got a duty as employers under the Health and Safety at Work Act to ensure that we look after the well-being of our people, and that includes both physical and psychological safety. And I know I'm not going to be here for a little bit of the conversation about things like mental health first aiders, but actually I would encourage all businesses to ensure that actually you have the same number of mental health first aiders in the workplace as you do physical first aiders, because I know from my own experience during the pandemic running this for the combined authority, our mental health first aiders have been a lot busier than our physical first aiders, because actually we're not having many paperclip cuts or sticking staples in your finger, or the odd heart attack in the office. Actually, we are having people in, forgive my language, but meltdown in the home environment because they're really struggling to cope, especially with emergency schooling that's taken place recently, and the expectation of businesses to continue in that space. So I think there's going to be a real challenge going forward that we really need to work on. And a seamless plug for Thrive to say, actually, we've done a lot of work in that space to help businesses shape their environment going forward, to support them with that agenda, and working with the partners around the table today. I think it's really, really important. So yeah, just hopefully that answers the question, Andy. And a big apology for me. I'm really sorry I can't stay for the whole event, but it's been amazing, and thank you so much for putting it on, and I hope it's added value to the locality. But some brilliant people out there doing some brilliant work, and we just need to make sure that we get that message out there as much as we possibly can. Thank you, Andy.
Thanks, Sean. I'll hand over to Elaine, see if she wants to comment in a second. We've got some great comments coming in, Sean, and I know we've got some great people from across the region who are really working in this space as well, and lots of stuff. There are lots of things that are being recommended in the question bar. We will include all of those in the resources that we, the information pack that we put together to send out after the event. But Elaine, do you want to just comment on the statistics around?
Yeah. I mean, we've something called real-time surveillance. So I said our stats were sort of 19, so anyway, a bit old now. But real-time surveillance, which really relies on police and coroner data, has shown very little increase in suicide rates during COVID. But please remember the stat about the impact of unemployment had after the last recession. So I think the issue is suicides aren't rising now, but we really think they will. And the risk factors such as social isolation, it's equivalent to smoking 15 cigarettes a day, the health impact of social isolation. Because we haven't mentioned older adults, they can be incredibly at risk of suicide. And they're often, people don't even think that when you get to a certain age, people don't ask about your mental health. So that's another plug for older adults. But yeah, we are concerned. And the complexity of people with mental health issues during COVID, everyone's feeding back to me, the people they're meeting with in mental health crisis, more complex than they were pre-COVID. So some very worrying things on the horizon, I think. Yeah.
Yeah.
Okay, thanks, Elaine. Yeah, Doreen?
Yeah, I think also as well to bear in mind, people working at home and quite isolated, again, we're noticing instances of self-harm, maybe excess alcohol, being drunk as well. So again, and we know that they're closely linked to suicide. So again, it's if you do have staff working from home, think about how you keep in contact with them, and just checking in on them and seeing if they're okay.
Okay, great. I'm just conscious of time. I think that we'll do a Slido just to give us a bit of a breather from that. I think there was some great information that we've been able to impart there. Hopefully that has added a lot of value to businesses. Let's do our next Slido, and then I want to come back. We did say that we would look at signs, how to spot signs either in an online meeting like this, or perhaps if you're in a one-to-one, and we'll try and take the conversation in that direction. With lots of questions coming in on the question bar as well. Too many to get through, but I will run through a couple of them as we're doing this Slido. Do you think you are more likely to die from a road traffic accident or from suicide? So we'll just give that a little bit of a minute to run, and let me just mop up some of the questions that are coming in. Okay. I'm trying to find lots of comments. Let me just see if I can find a question. There's a thank you there for Cameron's beer mats, Evan, from somebody in the chat. Do you have any guidance on how to introduce mental health first aiders and how to clearly define the role and support those people?
I'm a mental health first aid trainer, and mental health first aid give you lots of information, and it's part of the training as to how you do that. It's a very short answer, but yeah, once you've done the training, that's at the end of the training, we talk about how you encompass and embed mental health first aiders into your workplace. But yeah.
Okay, that's great. Okay, let's have a look. Blue space is being promoted and described as possibly better than green space for mental wellness. What are your thoughts on this? Anybody want to comment on that? I'm not even certain I'm aware of what blue space is.
No, I've not heard of that. I must admit.
No.
So we're learning ourselves every day, aren't we?
Yeah. So yeah, not trying to disclose names, but you know, the person that asked that, if you want to put the answer in the question box, then I think that's something we can share out. So our Slido, 80% are saying it's suicide, 20% road traffic accident. Elaine?
Yes, I mean, the reason we include that slide is, yes, it is suicide, but we think of all the money that we spend on road safety through car design, safer motorways. It's a bit of a plea to say we need to rebalance the money we spend on suicide, because you're more likely to die through suicide. So as a parent, it's your worst nightmare, isn't it? Your child being knocked over, but in fact, the more risk from suicide. Yeah, worrying statistic.
Okay. Okay, thank you for that then, Kirsty. So yeah, I did want to, we said before we launched the event, you know, how to spot the signs. And I know it's not necessarily that easy. If we have a situation like we were speaking about earlier, where you have somebody that's clearly delusional in an online meeting and there's crying in the background, that's quite easy to spot. But you know, spotting the signs of somebody who may be at risk of suicide, where do you begin? Where do you begin with that? And what are we looking for, either in an online or in a one-to-one in a workplace setting?
I suppose really, again, it's a vast area, but some of the things to think about are if the person feels very hopeless about the future, can't see a way through things. That's a bit of a warning sign. Also, as well, you know, if the person feels their situation, there's no way out of their situation, I kind of get this feeling of being trapped. That's a very common one. You know, if people feel trapped, and suicidality varies as well. So sometimes people can become very suicidal, but let it pass for an hour and then not so. So it isn't this kind of, it's not like an on-off switch. It's kind of this continuum, really, that we're all on. So I suppose really for me, helplessness, hopeless thoughts, being very self-critical, and again, if you're a team manager in particular, if you notice some change in a person, you know, they might become very withdrawn, or you know, there might have been people who perhaps would speak up at meetings and suddenly they've become very quiet, or you know, something's changed, something doesn't feel right. And sometimes we get those gut feelings for a reason, don't we? You know, so sometimes again, it's that reaching out to somebody, you know, just checking in with them. How are things? How's your well-being? How are you doing at the moment? You know, let's leave work there for a bit, but how are you coping with things? So I think sometimes just a general conversation like that can make a big difference.
I was just going to say, following on from that, there are some people who have exhibited what Doreen said and then suddenly seem very well really quickly. That can be a worrying sign, because they feel that the end is near, because they've planned it. So they seem to have a really miraculous recovery. And another one is where people start giving their possessions away. And people, when you spoke to people who've died, they said, yes, it's funny how he was giving away his favourite possessions. And in Japan, where there's a high incidence of suicide, where people go to a certain forest, they found that people were depositing their dog at a dog sanctuary. And so they targeted this dog sanctuary. Yeah, just little things like that. So people giving their things away, sort of preparing to die almost, and unexpected, what we call an unexpected recovery.
Yeah, and sometimes people can plan meticulously, you know, they'll make sure the dog's fed, the lawn's mowed. You know, people sometimes really do plan things very meticulously.
And just just to pick up on what both Elaine and Doreen have said, I think for me, one of the things is noticing change. So both Elaine and Doreen have commented on that. So it may be that somebody looks very scruffy and didn't used to, or it may be they suddenly look smart and they didn't used to, or it may be they're complaining they're only sleeping five hours a night, and for some people that's normal. But if it's change, look for change. You might, but you especially could look out for in people that you work with. And on the comment about asking how someone is, I mean, it's a great thing to do. And of course, but we've got this social habit that we say, how are you? I'm fine. And so that first pass doesn't count. You have to say, well, but how are you really? Or another approach, say, how are you today? Or how are you just now? Or how are you this week? If you anchor the how are you in time, it gives people the opportunity to open up in a way that they wouldn't if you just say how are you.
Yeah. Sometimes people use like a rating scale on a scale of 0 to 10 or something like that. That can, you know, at the start of a team meeting or something, you could do, you know, how would you rate your day at the moment or something like that. You know, just as a kind of a temperature check-in, really.
The time to change is a fantastic, very short film clips, and the one for I think World Suicide Day or World Mental Health Day was a man lying under a tree had fallen on him, and he said, "Are you okay?" And he said, "Yeah, I'm fine." So the message is ask twice. If you think someone's in distress and they say, "I'm okay," ask again. So there's some fantastic, really short film clips that make you think. So you could put those on your intranet, for example, some time to change or other things that are available through that website or through YouTube, and just to get people thinking and reducing the stigma. So we just talk about mental health. People say to me, cancer used to be a taboo subject a few years ago. We want mental health to stop being the taboo subject that we all talk about, and suicide being part of the discussion that we all have.
Right.
Yeah.
There is a comment around that that's come in. How can we get more people to talk about suicide if it's seen as a real taboo subject in a lot of communities? I think for me, just working with Thrive at Work, it's about getting that wellbeing conversation going from the outset, creating that culture in the workplace. So, because obviously suicide is an extreme outcome of poor mental health. So for me, I think it's the sooner we get the conversations going in the workplace, the better. And I want to bring Evan in here because we've said, what are the signs that we're looking for? But in your experience with Cameron, there were no signs, were there, Evan? Do you want to just talk a little bit about that? Not hearing you.
Thank you. Yes. So thanks, Andy. And yes, when Cameron died, nobody knew he was ill. And as I mentioned at the start, to the contrary, he seemed to be very well. He seemed to find his feet at university, and he seemed to be doing very well. And in fact, amongst the things we found after he died was a to-do list that included applying for his master's and so forth. So nobody knew that he wasn't well. And often you might find the parents are the last to know. And in Cameron's case, what was quite striking was when Carol and I met people in the days and weeks afterwards, and we met hundreds of people at the funeral. Nobody at all knew, and people didn't even know with hindsight. Cameron had behaved normally right until the end, and there were no clues. But I'll add that was, if you like, locally around the immediate period before he died. When Carol and I look back over his life, there were some signs that we didn't know at the time. So while nobody knew he was ill in the years before he died, there was one instance when he was 17 when he self-harmed, a single instance of self-harm. And Doreen mentioned earlier that self-harm is a big indicator of future suicide risk. We didn't know that at the time, and we're encouraged to think of the self-harm as an isolated incident that lots of teenagers go through, not to worry about. I say we were encouraged to think of it that way because we were, and also as a dad, I was keen to think that's what it was as well. I didn't want to think that Cameron might be wanting to end his life. But that was one sign which we now recognise but didn't know at the time. And another which was quite striking in Cameron's letter was the way in which he wrote about dyspraxia. He was diagnosed as an infant with dyspraxia, and the main impact on him was that his handwriting was slow and poor. And so during his school career, he got extra time in exams. And whereas Carol and I were continually impressed about how he just got on with life and succeeded and overcame the difficulties that his dyspraxia caused. When in Cameron's letter, he wrote about being tired of having to work 10 times harder than everyone else to keep up. So that was quite striking for us, because we thought of it as a positive that he had overcome his difficulty, and yet it was a wearing burden on him, which he had chosen not to discuss with anyone, and so it was really striking for us to see that in his letter. So in summary, yes, in Cameron's case, and in some cases in the immediate run-up to suicide, and that might be several years, there are no signs. But when we look back over Cameron's life, in hindsight, we can see a couple of things that we would treat differently now if we knew about it. So.
Okay, Andy, I'm going to have to go now, I'm afraid. So it's been a really interesting conversation and a really important topic. So I hope people who've attended today can get something out of it and some information, resources to share with their colleagues. Thank you.
That's great. We've loved having you, Doreen.
Okay, thank you. Bye-bye. Bye-bye. Bye-bye.
And just to say that, you know, the role that Doreen does across the Black Country, there are similar people in place across the region, and we will be sharing those contact details afterwards. I'm conscious we're into the last 10 minutes. There is a couple of things that I do want to just make sure that we cover. We've got lots of, you know, you've been a real great audience. The questions that have come in have been real good quality. We haven't really gotten to all of those, so I do apologise. We will follow them up in the literature that we send out afterwards. So I think what we've established is that the wellbeing conversation at every stage and at every opportunity is really, really important in building trust and creating an environment where people feel they can come forward. We know that we had an organisation where they had 3 people in one-to-one conversations expressed that they were feeling suicidal, and we were thankful that those well-being conversations were taking place, because it just meant that the environment was that person felt they could share how they were feeling, and those people you know, were able to receive the support that they needed to help them through, you know, that crisis that they were feeling as individuals. So we know the well-being conversation is very, very important. Evan, I just want to ask you, you know, the Cameron Grant Trust, you do quite a lot of work with businesses. Elaine, through Zero Suicide Alliance as well, there's quite a bit of resource and help available. Evan, do you want to just talk about what's available through the trust?
Yes, thank you. The main way that we highlight helplines available to community is using these what we call Cameron's coasters, and as someone in the chat said earlier, Cameron's beer mats. We call them Cameron's coasters so we can use his name, and so we're not mixing beer with mental health, because that's one of the rules of mental health. Alcohol and drugs always make it worse, despite how it may feel in the immediate time. So Cameron's coasters, which say there's always someone you can talk to on the front, and then have helpline information on the back. And this one has Samaritan's, Papyrus and Shout 85258, which are national services, but nearly all the coasters that we produce are localized to where they're used. So I've retired from IBM, but we had a version in IBM that had the Employee Assistance Program and various self-help communities in IBM, as well as services like Samaritans. We are here to provide these to any workplace that may wish to take advantage of them, whether in the national or customized form. We do the same thing in a business card form, which people can keep in the wallet. And we've just started a project, first it'll be in Coventry, where we've got reusable water bottles in the first instance for people living in the street with relevant help information for them, and water bottles for the homeless, because dehydration is a problem in that community. So you can see from the theme, though, the way that we aim to direct people to help is to work with the community to establish the help that matters most to that community, and then find an appropriate way of communicating it, whether it's a drinks mat, a business card, a water bottle, or whatever would work in your environment. And then in addition to that, I'll highlight this, somebody mentioned University Mental Health Day to Day. And this is a wellbeing postcard. It's got tips for looking after yourself that have been drawn by Cameron's cousin Kirsty, our niece Kirsty Ferguson, and we've made these available to universities and workplaces as well, and quite a few universities have shared the image of them for Mental Health Day today, so that's nice for us to see. And they've got the help information on the back as well. So as long as we've got money, and that's true just now, we make all these things available free of charge to any community that can use them. And the contact information, Andy, I know you'll be sending out afterwards, but our website is camgrant.org.uk, and coasters at camgrant.org.uk is the best way to get in touch.
Thanks, Evan. And Elaine, quickly, do you just want to touch on Zero Suicide Alliance?
Yes, it was set up by a father very similar position to Evan, called Steve Mallon, who got in contact with some senior leaders in mental health. And we had a target in NHS that we reduced suicide by 10%, and they said that's not good enough. Because it's a preventable death, there should be no suicides, so that hence Zero Suicide. And it's a fantastic usable website called Zero Suicide Alliance, and they're really pledging to get members of the public to take the 20-minute training. There's loads of information on there, and we hope, the Mayor of London, for example, launched a massive campaign to get the numbers up, and we're trying to do something similar in the West Midlands. So if you could all pledge to go on there, spend 20 minutes taking this training, and it's scenarios like taxi drivers. It's really drilling home to you that members of the public can help people who have suicidal thoughts. So please take that. Yeah, I'm really encouraging you to do that. And they do measure the number of people. There's no demographic or postcodes at the moment. That really want people to spend 20 minutes looking at this free training.
And the mantra of the training is see it, say it, signpost it. So it expands on some of what to identify, and say it is to talk about it and ask the question directly, and signpost it, which can be many of the things we discussed already. It might be 999, it might be the GP, whatever. But just to build on something that somebody commented earlier, you don't need to be a mental health expert to help. It's a simple human connection. Uncritical listening can make a huge difference. And I like in a related program the Samaritans had on Network Rail that they called Small Talk Matters. If you see someone that looks distressed, just ask them about the weather. You don't need to have any training in mental health. Just talk to someone, one human to another, and listen.
One person, sorry, the Golden Gate Bridge is quite a place where people go, and one quite famous person said, if somebody smiled to me, I won't take my own life. No one smiled at him, so he jumped off, and he was very seriously injured but survived, and now he's a campaigner. So we've had a World Suicide Day this year. We're saying please smile at people in the street, because it can just lift people's moods.
Guys, can I just jump in? We've had somebody ask where they can find the training that was just mentioned.
Just just type in Zero Suicide Alliance in Google or similar, and you will get it. It's so it's Zero Suicide Alliance.
We'll be sending all the links out as well.
And there's backup on there's YouTube film clips to go with it as well if you want to. There's lots of ways you can find it.
Okay, that's great. So just in closing now, this has been the first of our revamped Thrive at Work webinars. We've had a great attendance. The questions that are coming in are, I'm really appreciative of the audience, because you have been interacting with us. And that's been great. We want to hold future events probably quarterly. As part of the evaluation survey we send out, we're going to be asking you what would you like us to tackle next. It might be bereavement. We might look at that. We might look at the nation's return to work in June. We might look at the role of faith in well-being in the workplace. But we want to be led by you guys. So please do respond to the survey that we send out. It will help us keep these in a space whereby we know that the time we take is adding value. I just want to say this as well. So we've been talking to you as business owners, as leaders within your organization, senior managers, line managers, teachers, head teachers, people of influence who will be out there having conversations with staff. We've been putting this information across to you for you to share with your people. I'm just very conscious that you might be in this webinar and you might actually be that person who needs the support. So I want to say this: if you have had suicidal thoughts at any point, I'm asking you to reach out, use the resources that are in the handout field, pick up the telephone, speak to somebody. If you think that ending your life is the way forward for you, I would recommend that you go and get a second opinion from somebody who is an expert in this field. The telephone numbers are there. We're here as well. If you do feel that you need to talk to somebody, please do reach out, make that call, drop something in the questions box, drop something in the chat box. Don't leave here without a plan to speak to somebody if that is you. And that's where we'll leave it. Just we've got 60 seconds, so closing thoughts from Evan and then from Elaine, and then we will close the webinar. But thank you all for attending. Evan?
Well, thank you for the opportunity to take part, and thanks again to everyone who's joined. It's been great to see that so many people have been with us to talk and ask questions about this difficult subject. So thank you.
Okay, Elaine?
Thank you for listening to all of us today, and please talk about suicide.
Yeah, there are loads of resources that have been recommended in the chat bar. We will collate all of those and we will put them in the information that goes out. So just in closing, thank you all for making today such a really great event. Thank you.
Thank you.